The lecture is titled Rifampin, the Devil is in the Details, and our presenter is Dr. Roopali Jain, who's PharmD and the co-director of the Antimicrobial Stewardship Program at the University of Washington Medical Center, Montlake. She also has a clinical appointment in the School of Pharmacy and an adjunct appointment in the UW School of Medicine, Division of Allergy and Infectious Disease. And she is, at least our local King County groups kind of go-to for pharmacy issues related to really any infectious disease issue. So thank you for speaking, Roopali, and please go ahead and take it away.
Okay, thanks so much for inviting me. And I'm excited to talk about this. Drug-drug interactions are a lot of fun, and so I'm hoping that I can create some discussion and content, help with some content areas related to rifampin. So we're going to talk a little bit about rifampin pharmacology today, as well as some key drug interactions and how to use a recent guide that we developed. Here are the objectives that were approved by your group, really trying to identify key pharmacologic features, kind of help risk stratify the level of risk when you're co-administering rifampin, also understanding how to manage some of these drug-drug interactions. I will be using some acronyms. The main one is going to be CYP or cytochrome, and we'll talk about the context of that as it comes up. So first and foremost, and you guys know this better than I do, but why do we need rifampin for TB therapy? It's such a pain with all the drug interactions, but I think it's really important to remember it. It was, you know, earlier in this in the last few decades, it's really thought to be a game changer. And that's really because it shortened the effective length of therapy for TB, whereas previously it was 18 to 24 months. And when they did add rifampin, it did shorten this by almost half. And so it really has become part of the routine therapy for active TB. And it is considered one of the best sterilizing drugs, and it's considered it prevents that post-treatment relapse with patients with active TB. And then more recently for the latent TB, 4 months of daily rifampin based on a very well done study that the CDC is now strongly recommending it for HIV negative adults and children. And we'll go into that a little bit more, but really it is considered a game changer in the therapeutics of TB. So when we think about the first line therapies for drug sensitive TB, this is an image just taken from the NIH. Rifampin really works by binding to the mycobacterial DNA dependent RNA polymerase, and it inhibits the transcription of the DNA into the RNA. The big problem with rifampin, besides the drug interactions, is that resistance can emerge very quickly if given as monotherapy. And so this is just one, the bacteria can make just one mistake and basically renders it ineffective. So in the non-TB world, we really rarely ever use this as monotherapy because of this reason. And really in non-TB therapy, we are often using it in combination with other antibacterials. Okay, so the other indications that you might have patients on outside of TB, I will say we use it a lot in combination for prosthetic joint infections, often for endocarditis. And these therapies can be quite lengthy. They could be up to 6 months of therapy. And so clinicians that do manage these patients often are dealing with these drug-drug interactions with rifampin for these states. And sometimes, and as Dr. LaCourse will know, like sometimes we will opt not to use rifampin for some of these cases because of the significant drug-drug interactions. So you are not alone. Okay, so let's briefly go into rifampin pharmacology. So just the kind of the basics of pharmacology, we think of absorption, how it gets into the bloodstream, distribution, meaning where does it go, metabolism, and side effects. So first, it's very well bioavailable. That means when you take it orally, you get a lot of it goes into your bloodstream, which is great. It's modestly affected by food, but we really generally don't make a recommendation that you have to do one or the other. Distribution, this is important as we think of when we give an antibacterial, we want to make sure it gets everywhere in the blood, everywhere where the infection is. And lucky for us, rifampin gets almost everywhere. And the CNS penetrations can vary depending on the disease and the intact of the blood-brain barrier. The metabolism, this is really important to think about, because how does the body eliminate this drug, or how does it process it? And so it is metabolized by hepatic esterases, and basically it makes some metabolites that are excreted in the bowel. This is important because if it went through the kidneys, for example, then you would have to make dose adjustments if somebody had kidney dysfunction or whatnot. But for this medication, we don't have to do that. So that's why I included that there. And in general, and you guys know more about this than I do, is the side effects of these of rifampin is generally, we can see transient rises in bilirubin or transaminases. But when I was doing it, again, in the literature, it says true drug-induced liver injury, meaning that it has long-term effects, is really less common than some of the other agents where we think of INH and PZA can have higher rates of that. Again, this is what I found in some more academic. So you guys might have more experience with that. Also, it is the one that can cause rash as well. Among some of the other agents. But then also the big one is discoloration of sweat and tears. And so we can see patients come in if they're wearing their white t-shirts, they might have orange pit stains underneath. If they're wearing contacts, this will discolor their contacts. This also goes back to the distribution on how it goes all over in the body when we see this. In addition to this, it is what we call a strong inducer of many cytochrome P450 isoenzymes. And we'll go into what the relevance of this is. But really, this is what the main bane of our existence is that it has all these drug-drug interactions, and how do we best manage them? So what is cytochrome P450? And so when we break down how drugs are kind of broken down in our system, you have here the drug is taken, and these phase 1 enzymes, really what they do is they make them more soluble. So they add on making them basically more hydrophilic, so more water soluble. So they oxidize they participate in this oxidation phase. And then what happens is the drugs, when they are taken, they go through other pathways to either a detoxification pathway, or the same phase 1, the CYP cytochromes can also cause reactive metabolites. With some drugs, it can have toxic metabolites. And then eventually the conjugation piece is this, making it more water soluble. Then it's excreted from the body. Now, thinking back to rifampin, then, again, this is excreted in the body via in the bowel, and not in the kidneys here. This is an example of, I just wanted to also mention that unfortunately cytochrome P450 is also found in the gut lumen in addition to the small bowel. And so this is an example from the New England Journal, but it's about felodipine, but that part's not important. I just wanted to show the path of the drug when you take the rifampin. Again, the rifampin, you ingest it here, it goes into the stomach, and then here in the gut, there are some cytochromes that are in the gut that do affect absorption. In addition, once it goes into the bloodstream, it then goes into the liver, and then those are also where we have some cytochrome enzymes as well. And these are the ones that are more responsible for the drug elimination and excretion here. Okay, and so it becomes relevant as we talk about drug interactions, because there are some drugs that are more affected by the gut lumen CYP3A4s, and then some that are also more in the bowel. Now, why does this matter? It really just lends to the fact that there is so much variability in when you do give when you combine rifampin with other drugs, because not all drugs have the exact same profile. And that can be super frustrating. Okay, so what the main thing that rifampin does is that basically the net effect is that it reduces concentrations of many other drugs that go through this cytochrome pathway. And so the thing that makes it more difficult is induction. Really all it means is that the rifampin is causing more proteins to be synthesized. Because of that, that means that it takes a while for this induction effect to occur. And so here's the drug, here's rifampin. I'm not going to go into all the pharmacology here, but basically the net effect is that it increases the CYP3A4 both in the liver intestines. And so then when you give another drug that goes through the system, you will have more of these guys chewing up more of these cytochromes chewing up the drug that you are giving with it. And so potentially could render them inactive or maybe even more toxic. Okay. So in the converse is when you're washing out or when you're stopping rifampin, this inductive effect does take some time because again, these proteins have already been formed, these CYP3A4, and so it can take several weeks for them to go away and to normalize. So I'm hoping that most of the drug-drug interactions can be managed with clinical monitoring or doses modifications. We all take care of complex patients, and so this might not be relevant to your practice. I know for a lot of our transplant patients, this is not the case, but in a lot of our primary care patients that we can do a lot of clinical monitoring and dosage modifications. So I worked with the Curry Institute to help put together a rifampin drug-drug interaction guide, because really the number of drugs that are on the market, about I would say almost 50%, 40% of them do go through the cytochrome pathway, and that can be quite overwhelming as a clinician to kind of manage this. I will say with the advent of Paxlovid, I feel like people are getting more and more comfortable with managing drug-drug interactions because that also had a lot of drug interactions. So I'm hoping that we can learn from that experience and help make even better guides in the future. So this is a guide that is available online and to really help with kind of managing. And so what we tried to do is to include all the medications that are commonly used in primary care and really tried to delineate which ones you may or may not want to use. So for example, the green check is a very low risk and you can co-administer the medications without modifications. Low to medium, you can do it with caution, but maybe you need some extra monitoring. And same thing with the orange exclamation. And then the highest risks are generally contraindicated and do not co-administer. And I was talking to the panel before we started, and I will say that these recommendations are relatively conservative because we do want to make sure that people feel comfortable with using this, and you may need to use other options if you're not able to monitor the patient closely. So let's kind of go through some schematics of what this induction process looks like and kind of how to sometimes manage these drug-drug interactions. So one terminology that we use in pharmacy is the object drug. So this is the non-rifampin drug that is co-administered with rifampin. And so if you're using a chronic object drug with a new start of rifampin, so this is the chronic drug, you add on rifampin, you may see a decrease in that chronic object drug in 1 to 2 weeks if you do nothing, right? But if you would like to have the similar therapeutic effect, you will need to increase that dose of the object drug. Okay, and so really the time frame of that is about 2 weeks, and you will, need to increase that object drug. Now, based on the drug, and we'll go over a case example, you may want to do that right away, increasing that dose, that drug, or you might want to wait a week or 2 to do that. It really depends on this object drug that you're using. So what happens if for stopping the rifampin, if we're stopping the rifampin, you've already given that increased dose. What do? You generally have to wait for that 2 to 4 weeks for the rifampin effect to go away. And then you may want to decrease that dose back in 1 to 2 weeks. So there's that 2-week sweet spot there. That's a schematic that I just came out of my brain. I hope it makes sense. I'm a very visual person. So all those complex diagrams from New England Journal, I'm hoping this is a little bit more intuitive. So what about what if the patient is already on rifampin and you're adding on a chronic drug? So a patient is on rifampin, they've already been on it, and you need to add a new drug. Well, you can just give the new drug. You may give it at a higher dose, but you don't have to wait that 1 to 2 weeks because those enzymes are already revved up. And so that's another thing that, you know, as clinicians, you might get a question if somebody's on LTBI therapy and that you need to add on a new blood pressure medication. Well, those enzymes are already ramped up. And so you could just give whatever therapeutic dose you want. You may consider to be a little bit higher, but that effect that you're seeing with the new medication should be based on that current dose. Okay, so we're going to go into a quick 2 cases. And Dr. LaCourse has seen this. I've used this a lot in board review for the fellows, but this is a 44-year-old patient that's sent to the ER from his methadone clinic with a new fever and cough, and they're unhoused. The patient does have HIV with a CD4 count of 200. They are not currently on ARVs. They smoke 1 pack per day. They do not drink, but they've been on methadone maintenance for quite some time, about 5 years. The chest x-ray now shows a new right upper lobe infiltrate, and the AFB smear is positive. He's admitted for pulmonary TB treatment and started on RIPE therapy. His methadone is continued. On the 5th day of hospital, they appeared to be agitated and uncomfortable and complains of abdominal pain, nausea, diffuse muscle aches, but the vital signs are essentially normal. AST and ALT are slightly elevated, but generally okay. So what is the most likely cause of his symptoms? Rifampin hepatotoxicity, INH hepatotoxicity, opioid withdrawal, and immune reconstitution inflammatory syndrome. Well, and I didn't do a poll for this because those polls make me a little anxious. So just thought I would read faces and see, take a little pause there. But yeah, so it's probably the rifampin and the methadone, which is causing this opioid withdrawal. And again, you know, I just told you that it can take up to 2 weeks, but again, the induction can happen quickly, but it won't be its maximal effect until 2 weeks. So this induction of this rifampin, this is a clinical study that gave methadone with the rifampin, which is the pink, and this is the methadone concentrations. And you can see when it was given together, the methadone concentrations actually went down quite a bit relatively quickly. And so oftentimes in the hospital, what we are doing is we are increasing the dose of methadone preemptively, having a discussion with the patient, and we can monitor them and increase the dose. Also, the thing that we always note is once we stop the therapy, we may need to do monitoring for the patient to avoid over-sedating or an overdose. Now, a common question that I get is how much percentage do we need to increase this? Because and unfortunately, it's not just an easy formula. You can see here the concentrations can be quite dramatic, but not every patient is going to be the same. So often we do recommend, I recommend a 20% increase. You can monitor the patient for a few days, and then you may need to go up again. I don't like to do huge dose increases in general with rifampin because again, that induction period it can be gradual over time. Okay, and then this is what the Curry guide will say. It does have this orange arrow here, or exclamation point. It does tell you that methadone concentrations or efficacy is expected. And if you do need to co-administer for this patient, it it doesn't seem like we should stop their methadone maintenance that he's been on for 5 years. So they do say that a dose increase may be needed, and so that option is there as well. Okay, we'll move to the next case. 67-year-old male who had a liver transplant 5 months ago comes into the hospital with a new fever, cough, focal infiltrate in the right upper lobe. The patient reports going to India to see family in the last month due to an urgent family issue. The patient is on standard post-transplant medications. This includes immunosuppressant, tacrolimus, mycophenolate, Bactrim, and atorvastatin, which is a cholesterol medication. And so which medications do interact with this? Now, in general, whenever I get asked this question about drug-drug interactions, I always try to think of how serious are each of these medications for the patient. For example, the tacrolimus is really important for the liver transplant, and so we wouldn't want to alter that too much. Also thinking about mycophenolate, that's also used for the liver transplant. Bactrim is used to prevent the PCP. And then the atorvastatin is used as more of a chronic medication for long-term cardiac health. So that kind of helps me before I look at the Curry guide. So based on my review, these 3 medications do interact. Again, then we can go to the Curry guide to see what do they recommend. So because of these immunosuppressants being so important for the survival of the graft, they do recommend getting input from the transplant team or clinical pharmacist if you need to use these medications. From my experience, I've never been able to successfully have a detectable tacrolimus level in somebody who's on rifampin. So it is very difficult to do this. I have been able to use rifabutin before, but again, requires a very close monitoring and discussion with the transplant team if on the best management of this. Okay, what about atorvastatin? The interaction says that it could be either increase or decreasing of the statin. So again, it says co-administer with caution, and it's really recommending to look at this more information here. So again, it says for initiating rifampin, recommending holding atorvastatin for 5 to 7 days, and then restart at the regular dose, and that would be the case here. If a patient is already on rifampin, they have some slightly different recommendations where they say no dosage adjustment is needed, and you could just administer them together. Again, and this is really concerned for both an increase and a potential decrease. And then the last is Bactrim. This one I kind of think is a little bit conservative, but it's nice that that is in here. Again, it says co-administer for caution, and this is really based on the indication. And so indications such as UTI, skin and soft tissue infections, does recommend monitoring for reduced efficacy. For more severe infections, so let's say this patient is in the hospital getting high doses of rifampin, this might be more of a concern because you're really relying on that rifampin you're relying on the Bactrim to cure another concomitant infection that is more serious, such as like PCP or whatnot. And so I find this helpful to kind of help frame as much for this patient. I think that we could just monitor them and see if you look at the amount of reduction, it is about 23%. That seems like that's probably within the variability, and I would probably feel comfortable in a prophylactic setting to use this. You could probably just use Bactrim double strength and be okay with this combination. So I'm wrapping up to the end of the talk here, but I think some of my rules that when I do teaching is really thinking about some of how do I know which drugs to even check or start with for drug interactions. I really think of some of those narrow therapeutic drugs. So ones that if you do mess up concentrations, you're going to see an exaggerated effect or maybe an lack of efficacy. So those are like anticoagulants. You don't want to. I always truck for drug interactions when I have patients on that. Immunosuppressants or cancer medications, seizure medications, those are always really important. And antivirals such as antiretrovirals and antifungals are ones that I always kind of perk up my ears when I hear about somebody being put on rifampin, but also this Curry guide is available to help with that. The last but not least is the question that always comes up is, can I use rifabutin or rifapentine? In general, yeah, rifabutin and rifapentine are not as well studied. They do have less of a drug interaction than rifampin, but it's important to note that rifampin actually also goes through the cytochrome, so you can actually increase rifabutin levels sometimes when you're combining, so you can see more toxicities in some cases. I put this table up, and this is from the ATS IDSA guidelines, just with the different dosing and the availability of different capsules and things like that. But in general, I don't see them always as interchangeable, but they do have some less drug interactions the rifabutin does, but we can that's definitely on a case-by-case basis, and the Curry guide does look at each of these medications, the rifabutin and rifapentine as well. Okay, and that is it for my talk. As I mentioned, rifampin is necessary. The drug interactions are important and painful at the same time, but they're an important part of TB therapy. And then a lot of the interactions can be dealt with close monitoring and dosage adjustments. So with that, I will stop sharing, and I'm happy to try to address some questions.